Hello, everyone. This is Ashley Singleton. I am the iPrice Program Manager. Thank you so much for joining us today. Just a friendly reminder that this session is being recorded. Also, if you have questions or thoughts that you'd like to share, you can put that into the chat box. And after the presentation, we will address questions that are there in the chat. So again, thanks so much for joining us, and we will start in just a few minutes.
Okay, good afternoon, everybody. It's 12 o'clock, and so I'd like to get started here. I'm Jonathan Roop. I am the director of the Injury Prevention Research Center at Emory, which is hosting this brown bag series. So today we're going to do a brown bag lecture on opioid overdose surveillance given by Dr. Lance Waller. I want to remind everybody that we are recording this, so just be aware that this meeting is being recorded. I also want to take this opportunity to acknowledge that it is Veterans Day today, and ask that you all take a moment and think about our veterans and the debt that we owe them. So just to give you all a little background on iPrice. iPrice is a CDC-funded injury control research center. We focus on reducing the top causes of injury and injury death in Georgia and the Southeast through research, education, and outreach. We focus on really the top 5 causes of injury death, so overdose, falls, transportation injuries, traumatic brain injury, and violence. We have a set of 5 volunteer task forces, one focused on each of those activities. Those task forces are open for you all to join. You can find out more by going to iprice.emory.edu. iPrice as a center supports both a set of core research projects as well as pilot research projects. So our 4 core research projects are focused on preventing ACEs and suicidal behavior in African American adults through a set of novel interventions, implementing the Cardiff model for violence prevention, and studying how we might be able to improve that model as a violence prevention intervention. The Cardiff model is a data sharing partnership between hospitals, police, and communities aimed at identifying hotspots of violence and implementing efficacious site-based interventions. We also support a core research project that's going to kick off next year on how do we build resilience and reduce the long-term sequelae of adverse childhood experiences through a primary care-based intervention. And our 4th project, which is the subject of the brown bag today, is on application of small area estimation techniques to study opioid misuse and overdose in the state of Georgia. Our presenter today is the PI of that core research project, Dr. Lance Waller. Lance is a professor of biostatistics and bioinformatics at Emory's Rollins School of Public Health. He's a member of the National Academy of Science Committee on Applied and Theoretical Statistics. Lance's focus really is in spatial statistics. He's a wonderful resource for all of us, and we're grateful to have him working with the center and working on this pilot research grant. And so with that, Lance, if you'd like to share your desktop and unmute yourself, you can take it away. While you're doing that, just a couple of housekeeping items. I'll ask everybody to stay muted until the end of the presentation, and then submit your questions through the chat function as we go along. Ashley is going to keep track of those and let us know questions at the end. We'll go through the questions on the chat first, and then we'll open it up to questions for the audience. So with that, Lance, are you able to share?
Yeah, I'm just switching to mine. And if
just in case I have to stop first. Yeah.
There. Can you see my slides? Okay, great.
Got it. Thank you.
Yeah, great. Thanks for the opportunity. It's an overview of a couple of things, and it seems like most of my presentations, it's more of a work in progress than a completed analysis. There's some components that are completed, or people have completed their parts, but you'll see that surveillance never ends, and there's all kinds of complications in putting together lots of things. One of the things I find fascinating about public health surveillance is, unlike a lot of experimental design type questions, there's not a closed ending to it. We're looking for lots of different things. We have primary interest, but we also have secondary interest. So the surveillance component is interesting. The geographic component is interesting. Where are trends going up or down? Which places are high? Which places are low? Overdose mortality fits right into the Prevention Research Center, as we were talking before. But measuring overdose mortality and looking at this in both administrative statistics and others can be a challenge. So I'm going to talk about two projects, or the same project, two different parts. These are all collaborative work. One, because the issue is a challenge and because the data comes from multiple sources. The majority of what I'm talking about is thesis work from Sarupa Sarkar, who finished her Master's of Public Health in Biostatistics last May. And Priyam Patel was also a MS-PH student, but in Public Health Informatics. And the two of them did their applied practical experience in the Georgia Department of Health in their opioid surveillance group in the summer of 2019. We're really interested, worked with a great group with Laura Edison, Michael Thomas, and others, and then decided to do their capstone projects related to this. Priyam's is more on some of the data management elements, and Sarupa's was on the small area estimation. I'm also going to talk about some work we've done with Zev Ross, who runs a GIS consulting company out of Ithaca, New York. Zev's a really phenomenal person. And then Rob Lierla, formerly of SAMHSA, now at Michigan State, on some work looking at national level opioid mortality and overdose mortality statistics. So I'll talk about the opioid overdose mortality, some of the geographic surveillance elements of data sources, and then these two projects. It's not going to be a surprise to the audience here, but before COVID, this is one of the things we worried about a lot. The problem has not gone away, and in some settings it's gotten worse. But the use and misuse of opioid pain relievers, and then the introduction of synthetic opioids into the drug market have had dire consequences. In 2017, which seems like eons ago, but some of the mortality data most up to date is from this time period. You have over 70,000 Americans died from drug-involved events. This is greater than the numbers caused by homicides, vehicular accidents, gun violence, or HIV in any given year, not combined, but separately. So it's a very large component of preventable death that we're monitoring in the public health. The impact of the opioids in the system or use of illicit substances has taken a big share, and you can see around 68% of the drug-involved deaths involved prescription or illicit opioids. It was declared a national public health emergency in 2018, which directed federal funds towards a response. And then in 2020, we have COVID-19. So a lot of the surveillance work on opioids has involved some of the same people. And I mentioned working with Laura Edison at the health department, and she had moved from the surveillance group here to the surveillance group for COVID, and it was very busy with that. And then in the 7-year period, 2010, 2017 in Georgia, you see a 250% increase in opioid-involved mortality. Different parts of the country have been hit harder, or maybe say sooner than others, but you can see a leap in this time period. So those are just some background facts. The Georgia Department of Health has 3 state-level programs involved in substance use surveillance. There's the Opioid and Substance Misuse Response Unit, the Prescription Drug Monitoring Program that most, if not all, states have for monitoring prescriptions, particularly of opioids, but monitoring distribution of controlled substances through prescriptions. And then the Drug Surveillance Unit, which has the ongoing and routine monitoring of overdose morbidity and mortality, trying to identify any sudden changes or local changes in drug overdoses across the state. So in the sense of surveillance, monitoring what's happening to be able to try to respond quickly, we'll be looking at the county level patterns in the state of Georgia for our local aspect, and then look at some national and state level trends in the second part. This is a figure I use in a lot of proposals because it sort of summarizes what I try to do. So I think everything's spatial. So I have a hammer and I think every problem's a nail, but there's a lot of different parts of spatial. I originally made this figure relating to zoonotic diseases like Lyme disease and animals and climate and the interaction of all these. But David Klein at the Ohio State University, who also collaborates with me on some opioid space-time surveillance, converted this into the sort of social network on the left, the social ecology of community characteristics. This can be income, it can be access to services, social support, who's around you in your neighborhood to provide you support. Social systems, these might be health systems, they might be legal systems. So where are the law clinics? Where are the health clinics? What kind of law enforcement is there? What's the social environment? Are you engaged with your neighbors? Do you feel like there's interaction between the two? All of these are maps over the same neighborhood. And these different things combine. Here's a community characteristic that plays into the social environment and influences your local social support. And there's social systems that are plugged in. A new clinic opens, an old clinic closes. There should be arrows between all of these things kind of dynamically interacting. And within this environment is substance use. And we'll get a map of the true outcomes of interest. That might be who is using what, where, or in the case of mortality, where are the overdoses occurring and which overdoses lead to death. This is the map we would really like to see. That's the map of what's going on, when and where. Unfortunately, so those of you who've worked with substance use in the past, it can be difficult. It's it's an illegal activity for some substances. It's a hidden activity. People have a network of friends they work with in this who are all kind of in, there's a sort of a social contract on how they're working. But if that's not detected, either through law enforcement is one way, interacting with the health system through an overdose is another, that event doesn't appear in the map of detected outcomes. So the law enforcement filter on this is an interesting one in that it's not equally likely that an event happening anywhere shows up and gets detected, because law enforcement will focus on areas where maybe there's been activity in the past, or they may differentially go to different high or low income areas based on complaints of neighbors or who's in charge, who's making the decisions. So we get a filtered picture of this map we'd really like to follow. Now the mortality aspect, because death is involved and we have coroner's reports and death certificates, those can get in here, but we'll see later that there may be some differences, say from a state in the midst of an opioid problem and one at the beginning of the opioid problem in terms of how the deaths are recorded. So there's the detection of the event and then reporting it into an administrative data set, whether it gets listed as a underlying cause or contributing cause can depend on where it shows up in the final database. So that this whole continuum from, in public health, we usually start on the left or on the right with the official data and try to back our way towards this map. There's also individuals who do some of the like SIR models for infectious disease, but applied to substance use, trying to model the dynamics of the system and what comes out of what would generate it. So there's interesting problems all the way along. I like to have this figure because there's a lot of different ways geography plays into this. It can be driving how the system works, how people interact with one another, but it can also drive in terms of what data get into the final database. So what questions we're interested in, and we might know in surveillance as we're watching this for a given month or a given year, we want to know which areas or counties exhibit the highest risk, where are the hot spots. We'd also like to know where places are changing, which places are getting hotter, which places are getting colder. We watch these, perhaps as closely as we watch election maps. We want to see where the changes happen. Um, and then behind that is, how can we make it better? The first two are really just monitoring what's going on. But I think behind most of public health surveillance is, are there ways to intervene? So are there local risk factors? And epidemiology, we're used to thinking of risk factors, what's causing or what's associated with high rates or low rates. We can also think of resiliency factors. What are the things that could be in place that would make a trend not increase quite so fast, or might make a hotspot cooler? In my map previously, I had social support, social environment, social systems. What things can be in place that can change how this map looks? So we're hoping to see some insight on where things are happening, to start thinking about why they're happening and how they might be handled differently. So when we have questions we want to answer and we want to interact with data, some of you on the call have been in my classes. I use this slide a lot. When I moved to Emory 22 years ago or so, I went to visit the EPA Region 4 office downtown and talked to a toxicologist. We were talking about geographic information systems. And John Richardson drew this on a scrap of paper. And I thought it was really brilliant, and asked him if I could use it in class and in some write-ups I was doing. So this is the modal slide I show a lot of people. It's like most of my presentations. And I think there's a couple of people on the call who are in my GIS class, and they see this almost every time. But we start in the upper left. There's a question we want to answer. What do we want to know? Where are the problems? Where can we intervene? We can think about what data would we need to answer that question. And that we might need to know a lot. I'll kind of go through this exercise with substance use and overdose. But there's a compromise we have to make, because we can't follow everybody all the time. And some of the hidden nature of substance use makes it difficult to get data on who's using what, where, and how much. But we might be able to get some data that tell us something about it. Then we can answer some questions from the data we can get, but we have to double check and see how close the questions we can answer are to those we really wanted to answer. And we often go around and around and around. So we answer a question, we go, that's only part of what I wanted to do. What other data would I need? Let me see what I can get on those, and we go around. So you'll see a couple of aspects of this along the way, but we plugged our questions from the last slide here in the beginning. We want to know where rates are high. We want to know where trends are increasing, and we'd like to know where we can intervene. So I just repeat those questions again. So what data would we like? This is a kind of an endless list. There's we'd like information on a lot of things. We'd like to know where new events, incident counts and rates are, how many people in the county, and at what rate is it happening. To know the rates, we need to know the population at risk. We'll often use things like population size from the census, but in substance use, not everybody is equally likely to be participating in the activity. And so identifying, what is a saturation level? How many people would be using if they had the opportunity? So this is a question where the data we can get, how many people live there, maybe is a little different than the data we'd like to get. We'd also like to know information for these risk and resiliency factors for individuals. What role does employment have? What role does income have? What role does participation in community groups? What role does church have to the individual, but also to the county? You can have aggregate level events. You may not have the most expensive house in the neighborhood, but if you're surrounded by expensive houses, you have a different experience than if you have that most expensive house in the neighborhood. So some combinations of individual level, county level. There's state and local policies. This can relate to both law enforcement, but also service provision. There's different reporting patterns. Some neighborhoods may be quick to report suspicious activities. Other neighborhoods might not. There's different prescribing patterns across the state. We'd like to prescribing is an individual decision by a physician. And so there's some variability from physician to physician, but there's also individuals who have different prescribing habits for, both legitimate and perhaps nefarious reasons. So there's differences here. There's the distribution patterns, who's in control of distribution of both the prescription and non-prescription opioids, different law enforcement patterns, and then dot, dot, dot. We can think of a lot of things we'd like to know. The data we were using with Sarupa's capstone project, where we use Census Bureau data that provides us how many people live in certain areas. We had Centers for Medicare, Medicaid Services, some indication of individuals receiving, this gives us an insight into both the older healthcare population, but also the individuals who need assistance with medical coverage. We have additional information from Health and Human Services on top of that. The PDMP prescription monitoring program in the state, the Department of Community Health, Department of Transportation will show us roads. A lot of times we'll see patterns along transportation routes. And then the GDPH, HIV, and hepatitis C, and drug surveillance, and the syndromic surveillance group as well. There's a good collection of individuals monitoring lots of streams of data in the state. And a lot of them have been shifted to COVID surveillance as well, appropriately so, putting the skill set where it's needed. And Sarupa was presented with a list of 73 county level variables for consideration. That's a pretty long list. Some of the measures are similar to each other. There's different variations of income, there's age distributions and so on. So for data science, machine learning people, 73 is not that big. For statisticians and epidemiologists who did a couple of assignments on variable selection, that seems like, wow, that's a long list. Trying to pick out from 73 what the handful of most important ones are. The outcome we're going to think about here for this first map is the 2017 mortality counts from the Online Analytics Statistical Information System. These are drug overdoses for, and I put in bold, all drug poisoning mortality. So across all overdoses, not focused solely on opioids. I'll look at an opioid breakdown a little later. So when you talk about all poisoning mortality, it sounds like you just get a number. You get a number made of a lot of pieces. So from the death certificate record, you have ICD-9 codes for underlying and contributing causes. I'll break this down a little more. I want to show you 3 slides of, there's a lot of detail in this. We're kind of adding it all up for one number in this first analysis. But the X codes list accidental and intentional poisoning that goes into different drug types. The Y codes are drug poisoning of undetermined intent, which includes non-opioids, then anti-epileptic. So it breaks down by drugs as well. And then there are T codes as other cause of death. These are contributing causes, also broken down by drug type. A lot of these you see would be illegal drug types. And this last one, T40.6, is poisoning by other or unspecified narcotics. That's just the collection, often where perhaps a autopsy is not done. It's clear that it's an overdose, but it's not determined what it's an overdose of. So there's a lot of specificity in the death certificates, but doing an analysis on every single one starts to get some small numbers, and it starts to get complicated, and you can have multiple codes in this as well. I'll say a little more about that. Now, if right now we'll take the total deaths by overdose, and we'd like to get a county rate. So when you're estimating a rate, you usually take the number of events that happened over the number of people that were at risk. It's just a proportion of the people with the outcome. One of the challenges in estimating a rare event is that in small areas, is there's this tension between wanting a map with really small areas, so the map's very detailed, and a map that has good statistical estimates, so the confidence intervals are narrow, or your estimates are narrow. So the geographic precision would push you to say, cut up your state into as smaller regions as you can. The statistical precision would say, no, I want big regions with lots of people in them because I want a big sample size in each one. And so we want both of these things. So how can we compromise? The small area estimation uses some statistical modeling to try to do that. There's a third area of tension here that you're hearing more about with some of the census release, and that's the sense of privacy. And privacy statistics and differential privacy, you don't want to be able to identify single individuals. So if you get small areas, if you make them small enough, there's one person in each area, and we know who everybody is. If so, we can think of a triangle of trying to find the Goldilocks just the right amount of each of these. We'd like to have a detailed map. We'd like to have stable statistics, and we'd like to be able to protect individual information. So the statistical models, one of the phrases we use is we're borrowing information. So our compromise is the raw rates, that's the rates only from the data for that small area, are geographically precise, but statistically noisy. If I cut the state up into groups of 100 people and I have some 1 in a million events, some of my areas are going to look like it's 1 in 100. And so that rate's not a very good estimate of what's going on. But if I were to pool some information across them, that can help. So can we borrow information from counties nearby or from other counties? In words, what the statistical technique does is the estimate in a given county is a compromise between the data you have in your county and the other data. And by compromise, I mean it's a weighted average. And if I have a lot of data in my county, I don't need to borrow much information from outside. If I have only a little bit of data in my county, I might need to borrow more information. And you can imagine there might be differences between Fulton and DeKalb not having to borrow as much because lots of people are there, or Tolliver County having to borrow a lot because there's only 3,000 plus people living in that particular county. So different parts of the state will borrow differently. So how can you do that? There's some really kind of beautiful mathematics. This is the one slide with Greek letters, so those keeping score at home can fill this in. It's a Poisson regression model. So those of us who've taken epidemiology classes, we've done logistic regression and Poisson regression. We realize that's a good way to see how covariates are related to outcomes. So our count in each county will be a Poisson random variable. We want to look at a rate. So we have our county population there. We'll have an intercept. We'll have some covariates. I listed, we've had 73. I'm probably not going to include all 73 here. And then I'll have what's a random intercept for every county. I'm going to allow every county be a little bit different from the others. They all have the same association, but I kind of start in different places. By setting this up, the mathematics of this let this random intercept tell you how much to borrow from each other. There's a bunch of theorems and reasons it works, but it's a really useful tool for doing the borrowing of information. So conceptually, one way you could think about that is if we were back in a classroom in the olden days of presentations, we'd be sitting in rows and columns of desks, and I could give everyone an envelope with a small piece of paper, and they open it up, and theirs has 5 numbers in it. And I ask everybody to average those numbers and then raise your hand that high above your desk. So everyone wants to be the fastest, smartest kid in the room. So we all add it up really fast and we put our hand up. And then I look at the people next to me and their hands are all down here. So I'm going to scooch mine down a little bit. It's like how high I put it's based on my data, but when I look around to everybody else, I want to fit in. So I go down a little bit. The person next to me goes up a little bit. I'm borrowing a little bit of information from my neighbors and my data. They're borrowing a little bit from me. Overall, the highest of the high gets lower, the lowest of the low gets higher, and we get a smoother picture. So that's what's going on in the computer is this kind of peeking at everybody else's results and changing your answer just a little bit to try to get a better, more stable estimate. So what questions can we answer with this? We get a map where it's not quite as noisy. Everybody's a little more like their neighbors than if we completely ignored their neighbors. And we can get these estimates of what the strength of association with these risk or resiliency factors are. You can think of, median income. We can think of whether people have access to cars. We can think how far they are from a interstate. We can think how many clinics are there. Lots of different things that could go into this. The CDC and different state health departments have also created things called vulnerability indices from these lists of 73 or 100 variables to try to describe different communities. You could imagine 2 communities about the same size. They both have a factory closed, so there's a spike in unemployment. One of them ends up with an overdose problem and the other one doesn't. Was it just a coin flip, or was there some structure, social structure in one that gave more support, more resiliency to the residents than the other? This would be the kind of interesting thing we would like to be able to find. And we're just starting to think about ways to do this. The models in the background are these same kind of risk factor identification, but here it's sort of risk of not having a problem. So that's why we're trying to think of the word resiliency somewhat. What helps support that? So the potential risk factors, I said there are 73 county level variables that Sarupa started with. And we both felt that was a lot because we kind of grew up in the statistical tradition. And so a traditional statistical variable selection would start with a handful or a dozen and try to winnow it down to the best subset. In a machine learning context, you often focus on prediction more than what are the risk factor estimates. And you'll take a large number and try to group it into smaller numbers. So Sarupa's thesis, she looked at both kind of approaches, and where I'm kind of falling myself is I think the machine learning aspect and things like dimension reduction methods. Sometimes you hear about principal components or other approaches try to take that 73 and figure out what are the essential variables in that. So that's a good exercise to do. And then from that smaller number, we might take the more traditional statistical selection, because I'm interested in both how well I predict what the outcome is going to be and what the estimate of the strength of each risk factor is. So traditional statistics kind of focused on that estimation of risk factor strength for a long time. In the rise of machine learning and so on, recognize that prediction is really important. It is important to predict how many sales next quarter, how many flu cases and things like that. So it wasn't, if you look at the predictions of flu, the number of searches people do on a search engine for college basketball scores is predicted to the rise in flu numbers. It's not really related to the disease itself, but it does give you an idea of the time of year. So we can talk about this in the question time if we like. I just bring this up that all of us who took an intro biostat class probably learned it one way, and those of us who took a machine learning class learned it a different way. And they're sort of two extremes, and we're trying to bring the two together and get benefits from both. So what Sarupa did with the variables is they did an empirical review first, just went through the list and compared particular outcomes to what prior research was out there. This narrowed the 73 down to 50 or so, and they kind of grouped them into 5 categories. There are ones related to employment and income. There's drug-related activity, things that relate to prescription levels, how long you were in treatment. So this drug-related activity isn't necessarily an illegal activity, but what do we have records of in terms of prescriptions and use? HIV, hepatitis C infection status. We had probably more than your usual amount of information here because our surveillance grew out of the HIV Hep C surveillance system. There's household measures and community measures. So the Sarupa and her committee, through looking at the different variables, the ones that were similar, they would look at them and see what their associations were and kind of keep the one that had the strongest association to sort of thin things down a bit. She also used principal components to try to come up with combinations of variables. So maybe it's not unemployment per se, but it's unemployment and a neighborhood feature of how many other people are unemployed, or income, or housing value. So combinations of things. This cut it down about a half to 23. And then these were the variables she was using in our variable selection. She looked at them one at a time. So she had 23 different models, and she also looked at them as a group to try to find what the best subset was. We don't know that this is the model, but based on the data we looked through, there were 8 variables that stood out on their own, and then 5 when we put them in together. And the odds ratios associated with these, we're looking at the percent days for which someone had an opioid and a benzodiazepine prescription overlap period. So they had prescriptions for both. The length in days of the prescription for opioid, Percent of households with no vehicles, as you have more households with no vehicles, the mortality risk actually went down. So sometimes you think owning a vehicle might be a measure of socioeconomic status, but it's also kind of a measure of urbanicity. If you have other transportation options, you may not need a car. And then age-adjusted sexually transmitted infection rate, except for congenital syphilis, race, and the interaction of the two were all significant, but very small odds ratios. Part of that's the scale at which it's measured, but part of it is that the magnitude of the effect is not too big, but when you look at a lot of people, it may play into it. So these were the ones out of this longer list, which certainly wasn't every variable of interest, that showed up. You know, and then so these could tell us each county's predicted value, but we also did the smoothing to see if the map played out. All of these could have spatial impact in that they could play out in different parts of my figure from before. Here are two maps. The top is a smooth version of the observed mortality. This will take every county and compromise with its neighbors. So you see it doesn't change over space too fast, but you have this higher concentration in the northern part of the state, and then down 75 from Atlanta. You've got Augusta, and then you've got a high rate here in between both the highway to Savannah and 75 in a more rural area down the border with Florida. The estimated mortality is what those risk factors would predict. So the maps generally have some similar patterns, but the covariates don't quite predict the concentration in the southeast as strongly as it does appear in the data. And the particular impact, and so Augusta doesn't quite come up here. It's not just the covariates driving observations in Augusta. So the two maps I think are helpful because they sort of say, here's what the data would suggest, and here's what we're seeing, and we're getting part of the picture, but not the whole story yet. Now, both of these maps are smooth. We could have a map with the county-specific data, which would be bumpier and noisier for individual counties. Sarupa also worked with Michael Thomas on building some R packages for doing this. And one of the other aspects they looked at was how important it is to get data from neighboring states. Because if you're borrowing information from your neighbors, all the counties on the South Carolina border, Tennessee border, and Alabama border have neighbors over there, and maybe there's some information to borrow across that. So she did some earlier work on comparing with and without the neighborhood effects. I mean, without the neighboring states data. And we were able to get South Carolina, North Carolina, Tennessee relatively quickly. Alabama's data came in later. So we also explored having part of your neighbors and not others. So the patterns across the state were for all drug poisoning mortality. We see some evidence of risk factors. You can see that we were trying a couple of different analytic tools to get them. I mentioned the CDC work and the State Health Department of Tennessee's work on vulnerability indices. Robert Wood Johnson Foundation does some of this for healthy communities. I'm really interested in how those play out. That was kind of a direction my research was headed last January, and then in February and March, we all got redirected a bit. I think some of the issues that show up here in surveillance are similar in COVID surveillance as well. There are things we'd like to see, we don't get to see, and that this compromise between geographic precision and statistical precision maintains, and the same tools can transfer. And then, is the goal a description of the past or prediction of the future? We'd like to understand what's coming. That's why some of these ongoing trends, I mapped, these are the areas with the higher mortality rate right now. We could similarly make a map of what's the rate of increase of the rates in each county over the last 5 years or 10 years or something like that, to find out, are there emerging hotspots to keep track of? So this map is just one number, that's our mortality outcome, but we might be interested in, where is this going? Is it increases or decreases in certain places. We might also be wondering if each of those risk factors might have a different association in different parts of the state. The factor, some of the risk factors we talked about, it's not whether you have a car or not that causes you to overdose. Having a car or not is a marker of some other aspects of your lifestyle. Similarly with race and sexually transmitted infections, those aren't the biological reasons for this, but they are related to your social determinants of disease as well. So there's really a lot of rich work to do in here and more things to learn. I said conclusions, that's a little bit of a red herring. I have a few more slides. So everyone was getting really relaxed that we were gonna have plenty of time for discussion, and we will, but there's a couple more items I wanna talk about. One is, okay, we did all overdose. Can we do opioid mortality? That's sort of what I promised in my title. So those ICD-9 codes I showed before, the X codes, the Y codes, the T codes, they provide more nuanced details. And the National Center for Health Statistics can offer you access to the national mortality. You go through an approval process. So we did that. And Zev Ross, again, I mentioned him at the beginning, his consulting group does just phenomenal GIS health work and a lot of data science work as well. So we partnered with them using the 2000 to 2017 mortality data, looking at both the incident mortality, the new deaths listed in death certificates, and looking for some hidden patterns of reporting changes. Anecdotally, when we first started looking at some of the data, there was a weird pattern in a certain part of Massachusetts. And it just seemed like there was, the numbers had changed quite a bit. And we said, what could possibly be going on? And in the meeting, we Googled Massachusetts coroner overdose. And you found that a former coroner had been fired for not filing, completing the autopsies and filling out the data. So you could actually see this impact. The pattern in the data was due to a reporting problem, not so much a outcome problem. So that I'll show this picture one more time. So it's one talk and I've showed the same slide 3 times, but different things happen in different places. So this pattern of how reporting varies is somewhat fascinating to me, because what we see in a data set is a combination of what's really going on and how we collected the data for that. And both of those can vary by location. So defining opioid mortality, so this is some of the work with Zev in the CDC guidance on defining this. The underlying overdose, death certificates will have a primary cause of death, but they'll also have contributing causes. So an underlying overdose would include these unintentional X codes and intentional poisonings. Those are the X codes. Those of undetermined intent, so these are the Y codes. It's not intentional or unintentional, but it's still poisoning through medication, and homicides by drugs. But there's also up to, I think, 10 contributing causes, and those are where these T codes come in with specific drugs like opium and heroin, opioids. Other opioids have a collection in this other and unspecified narcotics. And so any opioids kind of included all of these together. Zev put together some really nice plots. This is a paper that was almost done last January and remains almost done, which is largely my fault. It's been sitting with me for quite some time. But these are some of the trends you can see in the data. Again, we're going from 2000 to 2017 was the newest national release we had about a year ago. You can see the different types. This shocking blue one is the rapid increase in synthetic narcotics. This is the introduction of fentanyl and others you see. Opium itself is relatively flat, not opioids, but opium. Other opioids you see coming up, and heroin's relatively stable. The unspecified narcotics is the pink line. I'm going to show you 2 slides with some graphs summarizing things. These are trends. There's a line for every state. The red lines are for the 10 states with the highest overdose death rates. And the blue line is the median of the ones with the lowest rate. So as you might expect, the red one's on top, the black one is the national median, the blue one's on the bottom. So for heroin, some increases here. Methadone is about, just the states are pretty well mixed. Here in heroin, the highest ones are the highest overdose ones are the highest heroin ones. The other opioids are mixed together. The synthetic ones, the ones with the highest overdose rates were also the ones with the highest synthetic opioid rates. So they're contributing to this sharp increase. And then unspecified narcotics has this pattern of, in the states with the highest overdose rates, of it going down. It doesn't necessarily mean there's fewer of them. Oh, well, it doesn't mean there's fewer overdoses. It means fewer overdoses are classified with that other category. I contrast this with the preliminary work we're doing. Remember, the red is these are the states with the highest overdose deaths, but I look as where the overdose is listed as a contributory cause, but not the underlying or primary cause. Places with high overdose rates, that doesn't happen very often. So states with high overdose rates will generally list the overdose as a primary cause. They're familiar with this. They're dealing with this quite a bit. The places where you have an overdose listed as contributing, but not the primary, so that still could be a death related to an overdose, that reporting pattern happens more often in states with lower overall overdose rates. So here the blue line's on top of the red line, and that's kind of indicative of slightly different reporting patterns. That's our conclusion so far. We really need to look at this some more. Similarly, the trends in overdose deaths reporting for unspecified drugs, the highest ones are in the low overdose states. Now, this can be a situation where, especially as this will be interesting to monitor going forward with the national public health emergency, because there's federal support available based on the opioid overdose rate. So there's some interest in making sure we check every overdose and get it properly classified. So there's incentive to not just use the other category, whereas the other category may be a catch-all. So this is not saying anyone's doing anything wrong or untoward, but that there are some differences in patterns kind of based on the background level of overdose rates that we're seeing in the states. And some of that's just experience, and some of it probably is effort available and encouragement to provide the full information. So I want to leave some time for some questions. Feel free to put those in the chat box. This is a challenging issue. Substance use epidemiology is challenging because it's not something that often people want to reveal about themselves, but the public health consequences are severe. The accidental overdose deaths are things we would like to be preventable. The data are challenging to work with. I gave an example here where we pulled data from multiple administrative sources. There's also there's interesting work using social media data and so on people identifying and their use and so on. The analyses are challenging because we're trying to balance these desire for a detailed map and precise statistics and maintaining individual privacy. And then I think everything has a geographic pattern. So again, there's geographic variation in mortality. There's geographic variation in where the risk factors are high or low. There's also geographic variation maybe in how that's associated with mortality. And then what I'm hoping to leave you with the last couple of plots was that there are geographic patterns in reporting practices. There's some variation in how the data are collected and reported. There's no group standing out as always underreporting or things like that. But trying to, figure out what the real counts are. We're seeing a lot of that play out in discussions about elections and so on. But, this goes into all of our health data as well. We'd like to have all the information, and we use what we can get. And some of the observation processes may vary from place to place. And so I think there's a lot more work to do. I hope this is, interesting summary. It doesn't have any final answers for these, but I do, we definitely appreciate the support in examining it through the Prevention Research Center. It helped spur some new collaborations. Our work with Sarupa and Priyam and Michael and Laura and others has really gotten us thinking about new directions to go with these approaches. So thanks for the opportunity to present, and I'm happy to entertain any questions.
Awesome. So thank you, Lance. Very much appreciate the presentation and acknowledging the wonderful collaborations that your projects have helped facilitate. I'm going to just ask a quick question, just because there's so much I'm interested in this. So you showed how some of the some things suggesting that there might be state-specific factors that influence how overdose deaths are reported. Have you looked into whether those trends hold up on a county level? I'm particularly asking because some states like Georgia have both medical examiners and coroners, where coroners are, an elected position.
Right.
And we do see quite a bit of difference in reporting between those two groups. I wonder how much of that might explain some of the trends that you're seeing.
Yeah, I think that's a really interesting question, because we've looked at it a little bit in Georgia, not at the same extent with the full death certificates. But looking at it county by county, the numbers start to get smaller again. It's like you want a better map. But I think you're absolutely right that there are different patterns. Some places will have had the same medical examiner, for a long time. Some will have newer people. So I think there's definitely variation there, and it would be worth, just a reminder, our goal is not to try to find any bad actors per se, but if we could just get a handle on how variable it is, I think that would help a lot. Especially with the overdose component, it's an acute and often it strikes people at young ages, or it's an avoidable death is what we would like to think. And to Sharon's question, should we look at age and factor? I think we should with older adults. The opioid overdoses, it's a different sort of exposure, because you've got both the prescription and the illicit. And then you also see some people moving into illegal use because of the addiction during the prescription period. So it has a different kind of age factor. Age of the individual and how the deaths are recorded probably has some aspects as well. A map of where positions are appointed and where they're elected might be illuminating too. I don't think those are variables that we considered in our 73 list, but it clearly would impact, or likely it could have an effect on what's reported and what's not.
Yeah.
So I have another question here, wondering about the prediction model can be used to estimate association between risk factors and mortalities, because it seems only significant covariates are included. Do we need to consider other possible confounders? Yeah, I think one of the challenges of prediction is our statistical approaches are finding association. And that association might be strong enough to give a good prediction of what's coming next. The confounders, we're interested in a lot of different dimensions of this issue. One of them would be, what are the causes and potential confounders and places we could act? And other ones are, what are good predictors for the outcome? So the car ownership thing is kind of an aspect there. I think it's a proxy of alternative transportation availability right now. My hackles go up when people say their main goal is a predictive model, because I want to say predictive of what and predictive for whom. Is it actionable information? And I think that's a slightly higher bar, and I would encourage us all to try hard for it. But I do think Chi's point that there are confounders to this. We've got confounders on confounders. And so this is quite a difficult, just pure epi problem to try to get to some of the causes. And they likely vary by age group as well. So Beat's got a question about smoothing of the mortality rates. Are there strategies for finding optimal parameters for this? I like to use these hierarchical Bayesian models because it's estimating the amount of smoothing it needs to do. That sounds a little circular, but there's some kind of lovely mathematics behind it, that it's trying to do the right thing. It'll borrow more when it needs more and borrows less when it does. What pops out of it is a weighted average, but the weights come from these associations of how you set up the model. It's not as straightforward as the Poisson regression we do in our epi classes to start with, but it's not that much more complicated. So I like it because it's using the data to decide how much to smooth. You can also have parameters, or even have like a GIS thing where you'd have a slider for how much to smooth, and then you can kind of go for what looks good. And there's a lot to be said for that as well. But I tend to like the ones that are estimating that smoothing from the data. And these small area estimates have been around for the family of models has been around for a while, and it seems pretty robust. I mean, there's some certain ways it can make mistakes as well, but that's in a sense, that's my happy place. I like working with those models, so I'm a little biased, but I do think it works out well. It's not just a heuristic ad hoc kind of adjustment, but we have lots of different disciplines looking at this. So we'll have the substance abuse groups, we'll have data scientists, we'll have statisticians, we'll have epidemiologists. And I do think there's a lot of value for collaboration between the two, or between the groups, because we all have our different go-to approaches. And it's a hard problem with messy data.
Yeah. I was gonna say, I have one more quick question, just because this is, I've been curious about this ever since you talked about it. What happened? What was the result of including data from neighboring states on some of the estimates that you got? I was just curious. I think because it's an important problem.
Yeah, we found it was a little helpful, but it wasn't a make or break addition. So things did not change too much. If they had, then it would have been, the recommendation would have been, we need to have some consistent data sharing, which I think is always a good thing. But it didn't, my recollection is it wasn't we didn't get a shocking result. And, but I think we got a slightly better result. So it helps. It may make more of a difference in smaller population states, or, the counties in Georgia are all about the same size. So we have a nice map to work with. In the Western US, the counties can be huge or small, and the smoothing gets a little, you have to make different choices there. So.
Awesome.
Do we have time for one other quick question? Lance, from a community-based organization perspective, how should they respond to this data or outcomes from a project like this? What could they do if they saw some of these results?
Yeah, that's a good question, because we like working with the math, and we're happy it all works out, and we get a map and we kind of think, well, that should just do it. I think the communication translation piece is really important. So I think the maps are a good meeting ground. People recognize they're part of the state. They recognize where the highways are. They recognize that our county is a little better or a little worse than this other county. So I think that I find it's a place we can talk. And we're starting to do some work with some community groups on environmental issues. And part of it is coming up with a standardized way of presenting it. So we're not having to figure out the map every time there's a new map. We kind of are used to seeing it a certain way. So I think I'm still trying to learn to describe things without dropping back to my Greek letters and computer code, and come up with good metaphors for what's going on, because there is intuition behind it. And so we want to say we get a better estimate by looking at our neighbors. And I think we can explain that somewhat and then say, when we do that, here's what we're seeing. I do think it's helpful to show the raw data, which I didn't do today, just so people know these are my actual numbers, and then these are the numbers that are a little cleaner. I've gotten some of the noise out of it. But thanks. I think that's some things we can really continue to work on. And we, the partnerships between the community groups and the researchers, I think we need to make that, you have to be conscious about it being a two-way conversation. It too often just goes in. One group's talking and the other group's not listening, and they take turns doing that. So talking louder doesn't convert, it doesn't translate well. So maybe we need more training as well, and more spaces to do that, like this.
Yeah. So Lance, I think that's a wonderful place to end our brown bag. It's 1 o'clock. So I just want to thank you again for the presentation. I think everybody enjoyed it and we learned a tremendous amount. And so I also want to thank everybody who attended and asked such great questions. And so be on the lookout for notifications of future brown bags and future webinars that iPrize will be doing. We'll update you on this project and others. So thank you again, everybody.
Thanks, everybody. Appreciate it.
Okay.
Have a great
Bye.
day.